Okay, we're going to start the webinar.
Bueno, vamos a iniciar el webinario.
Good. I hear the translation. Is that normal? Mehdi. La traduction, on l'entend. Okay. Good. So we're going to start, and this will be, I think, a very interesting webinar because we'll also interview Dr. Jacob Teitelbaum. Jacob, can you put your video on? And Jacob? Okay, good. I see you. Jacob, I just want you to present you. You're a physician from the United States. You're, I would say, world famous for working on the chronic fatigue syndrome and fibromyalgia, and also the post-COVID syndrome now. So we'll talk about that later. Well, just say hello, and we'll see you then later in the next presentation, at the end of the presentation.
Well, welcome everybody. So for those of you who have treatment, who have people with chronic fatigue syndrome, ME, or post-COVID symptoms, we are going to teach you how to get them well today. It takes an integrated program, but this is very, very doable.
Perfect. So I will start, and this will be a shorter presentation than I usually do. So after 50, 60 minutes, I'll be able to interview Jacob. So let me share you my screen here. And Jacob, you can take out your video and your audio so we can work on. Voila. And here, so there's only a Spanish translation. There's no French translation, as a person just asked. And we're sorry for that, but we'll try to have one in the future. And so this is Jacob Teitelbaum that will be interviewed at the end of the presentation. And I am sure you will learn a lot, and me too, actually. So good. So let me show you what's it about. I'm actually presenting here during a small hour the model on the hormone therapy consultation. And it's a model actually where there are several sessions. There will be a session on the medical history and actual complex. It's actually very fascinating. I will also talk to you about the spirit of the consultation. How inspiration comes during the consultation. And when you do a hormone therapy consultation, you're probably touching on one of the most important tools to get patients well. So the first session, there's about a 2-hour session on medical history and actual complex. It's very interesting. You'll also get PDFs of questionnaires to use if you are registering for this model. We'll have explanations on the diet, what are the recommendations to give for the patients so that the diet actually stimulates and improves the outcome. We'll also have extensive 2 sessions of 2 hours on physical examination. Session 2 and session 3, we'll see everything, and you will see it's very interesting. We'll get a lot of pictures on many hormone signs, and I think it's probably the lectures where you have the most of these. And we'll have also laboratory tests where interpretation, explaining how to explain to patients the results, give examples, how you conclude for things. And specifically, this will really be helpful to get the best lab test you can have from the patient and the best interpretation. And then we'll have 2 sessions also extensive on hormone therapy treatment. So it will be a real review of what we have seen in some other models, but it will have everything together so that even this model alone will be enough to give you a lot of very, very interesting information. So that you really can compare doses and you will really have a good knowledge of what to do. And then we'll have also follow-up, and the follow-up we'll see a lot of pictures before and after of many physical signs of hormone deficiency on all locations: the ears, the chin, the eyes, the eyelids, the chest, the pelvis, the legs. So really, really interesting. And then we'll have some practical patient cases like in every model of this cycle. And we'll also have an additional PDF that has frequent questions from patients and how to answer actually the most frequent questions and the most embarrassing questions, but with a good outcome. And there is, and that's separate, a whole nutritional therapy program, but I just mentioned it. There's one that is part of the hormone therapy consultation for the nutritional therapies that gives all the information on the nutrients that can stimulate hormone treatments or improve their activity. So really a lot of interesting things. So let's look at session 1 and let me give you an interview. So basically what we'll have in session 1 of this model is that we'll talk about the appointment, about questionnaires and lab test requests that you need to make. There will be, for first consultation for diagnosis, you'll have to collect personal patient details, and we'll provide additional to this model some questionnaire how to do it. Also questionnaire for the personal medical history, the family medical history, and then very important questionnaire specifically on hormone deficiency and excess complaints. From many hormones, thyroid, adrenal, sex hormones, melatonin, but so much more, vasopressin, growth hormone, oxytocin. This will really be a very interesting part if you do on hormone therapy. And then we'll have also nutritional deficiency complaints, a questionnaire for that, mostly on magnesium, iron, vitamin A, but there are many other nutrients, but that's more part of the nutritional program. To be more extensive, the diet, also extensive questionnaire on it that helps you actually to really optimize the treatment of your patient. And then we'll have also, I skipped here a little bit, sorry. They will have one on pollution questionnaire and then a sleep questionnaire, so that really at the first consultation, you get a good idea of what the patient presents as a problem. And so let's just look some little clues of some slides that we'll see. For example, we'll talk about the medical secretary, what she needs to give us information to the patient. So she has the first contact. It's very important that she does her work well. She gives the appointments, sends by email questionnaires, sends also provide by phone information on consultation, what are the fees, the opening hours, lab addresses, even sometimes hotel addresses for patients coming from far, for how to do for cancellation policy, etc. We do have for the appointments, for example, for my own practice, we have a website where they also patients can take their consultations. And then there are some advices that you really need to know, because remember, I'm talking that there's a spirit. If you do on hormone therapy consultation, you're already a person who sees far ahead, who sees a little bit further than maybe your colleague does. But you need to have some tips that really make your consultation better. And so advices to improve data collection or diagnosis, one of the advices is that you absolutely, before any consultation with the patient, need to send questionnaires to your patient about his hormone deficiency complaints or excess complaints he may have. So the first step is really doing that actually. I'm having a little problem here with So patient fills in the questionnaire and patient sends it completed by email beforehand so that the medical record is really prepared. And then the advice is really to do this. You need to have a questionnaire that you need to send to patient. It will spare you a lot of time, and you will also be more complete because you'll do a tour of the important questions. This is also valid for the follow-up. And so listen to your patient is something my father always used to say. For those who don't know, I'm the 4th successive generation of doctor, and we always have worked in hormone therapy from my great-grandfather on. And my father taught me the basic skills of it. And his advice is that you should listen to your patient because he is or she is your master. The patient really provides the problem, but also often provides the solution if you listen carefully or you ask the good questions. So basically, listening is a tool that is really helpful for the doctor in a hormone therapy consultation. And there's for example, the data that you collect with medical history, personal, familial, and everything, you can put that on a paper. I have here an example of paper that will be provided in here. It's one of my older papers, but actually it helps well to give you have an overview. I like to have everything overviewed on one page. And then further on, for when we have symptoms, we write the symptoms here on. So if you have handwritten a medical record, that is possible. Now we have a computer program, and actually it's not so practical, but basically you will be helped with this paper. Diet advices to give. Many people know. What I probably will say is that the optimal is to have the largest meal with most proteins and a sufficient healthy fat actually in the morning. The breakfast should be the most important one. And also you never should cook quickly your food, especially not proteins and certainly not fat, because otherwise you make them toxic, you burn them. If it becomes hard here, the food, then it's a sign that you have overcooked and that you're getting toxic oils and fats. So oven at low temperature at 85 degrees Celsius, 185 Fahrenheit, otherwise the food will be bad and the patient will be spending her or his time digesting and trying to fight the toxicity and not responding well to the meal. And our reading raw, we do that in Europe often. I know in America, they would say, oh, they like to cook everything, but basically it's healthier if it's fresh meat. It's healthier. High protein diet is actually also better for hormone levels, especially hormones based on the structure of cholesterol, like cortisol, testosterone, and estrogens. And here's one study, for example, showing that high protein diet compared to a carb diet actually increased by 37% your cortisol level. So don't eat sugar, sweets, or even bread, because that will put down your cortisol. And high protein diets also give the safer estradiol metabolism. You know that estradiol can form into carcinogenic or procarcinogenic metabolites, and you can decrease that by putting the patient on a high protein diet compared to high carbohydrate diet. There's 33% more 2-hydroxy and hydroxylation of estrone, the metabolite of estradiol. So basically, it's much more, it's better this way. And okay, then there's so a high protein diet may really decrease the cancer risk compared to high carbohydrate diet by improving the metabolism of estrogen. Now, also we overview in the first session the sleep, because it's very important. You can already help at the first consultation your patient by giving some sleep advices. And just to give you an idea what poor sleep or not sleeping enough does, 2 days of sleep restriction, like 4 hours of sleep and not more, decreases hormone that decreases appetite, leptin, 18%. It increases by 20% the ghrelin, which is a hormone that actually stimulates appetite. And it improves more the hunger, and it improves especially the hunger for calorie-dense foods like high carbs. So basically, if you want to lose weight, you should sleep enough and well. And there's a lot of advices that can be given to patients how to improve sleep, but that's not the topic of today. And then we see here the physical exam part 1, where we'll basically see the whole body and the head and the neck and all the hormone signs that can be there. And so important is to really in this session to look at the body silhouette. We'll learn about to look at how important it is to measure the height, the weight, the muscle mass, the bone mass, sexual characteristics, and then how to examine the scalp here, always with pictures with signs of hormone deficiency. And the face, the global appearance, what it tells us. Globally, you can see if it's a growth hormone deficient face, thyroid deficient face, estrogen deficient face, testosterone deficient face, and so on. Forehead, The eyes will be examined, always with pictures of the hormone deficiency. That is important to know. The nose, the lung examination, how to listen to the lungs, how to listen to the heart also, and what it may give. If you hear an arrhythmia, for example, the heart, if it's slow or quick, it's a different hormone deficiency that may be behind it. Blood pressure, lips, the gums, the teeth, the tongue, the cheeks, the jaws, and the chin. Ears. Patients at my consultation usually say, well, it's impressive how much you examine everything at the physical examination, because they usually say we never had such an examination. But it's really, I'm not doing it to impress the patient. I'm doing it because it helps me to fine-tune the patient. I know if it's a hormone therapy, slightly too much or slightly too little. And it gives me this inspiration that is necessary to arrive to good diagnosis. If you hesitate, examine the body of the patient. And often, if you know well the signs, you will be able to recognize the deficiency or excess that there is in a hormone. Physical exam, you search for physical signs of hormone deficient excesses, but also for nutritional deficiency. So there will be some information about nutritional deficiencies here too. So let's check the patient's height to give you an example of what I'm doing in a consultation. The patient can be tall, like this guy, or small, like this woman. And that actually gives us a different idea of what hormone deficiencies have been in the past or hormone excesses in these patients. So for example, this patient actually is a patient with thyroid deficiency. Hypothyroidism in childhood, has not grown tall, and is larger of body. And all these characteristics also look swollen in the face compared to the others. Thick muscles, robust stocky trunk, shorter limbs. The limbs are shorter comparative to the trunk, and swollen calves. And this is different with a person who has had growth hormone deficiency in childhood. Is even smaller in general if the growth hormone deficiency has been severe enough. But normally developed muscles, not those thick muscles full of myxedema, and normal proportions of the face and body. And also, you should check the patient's weight. That gives you, for example, cortisol deficiency in childhood gives an aspect like this: is thin with hollow cheeks, thin face, I would say, but thin body, low body weight, low in fat muscles. There's a typical cortisol deficiency since very early in childhood. But when it has started insulin deficiency in childhood, even without diabetes, you get this aspect, much thinner even. The person is thinner, thin body, very low body weight, severe lack of fat and muscles. So, and then of course, obese persons is different aspects. Let's look a bit at what some of the slides we see for the scalp hair. You see, for scalp hair, the hair can be dry and brittle. And hormonally, the most frequent deficiency behind that is actually hypothyroidism. Also low testosterone, low estrogen, low growth hormone, IGF-1 can also be with dry hair. But hypothyroidism, especially if the hair is thick and rough, thick, irregular, rough, myxedema in the hair, so thick, then you're sure the dry hair comes from low thyroid. And now it also can come, you see this also dry hair from nutritional deficiency like iron, zinc, B2 and B5, or omega-6 polyunsaturated fatty acids. Actually, the driest hair comes in people with a lack of omega-6 polyunsaturated fatty acids. So you need to give them borage oil or evening primrose oil to correct that. So physical examination, when we look at the face, the face of a man can be looking female-ish. That's very rare, and that's in case of a lifelong total lack of dihydrotestosterone. Or the face can look boyish, like a person has a severe deficit in testosterone, dihydrotestosterone. And then the face can look like a man looks very male here with adequate testosterone, dihydrotestosterone levels. So looking at the face gives you already clues of what happened in the past in testosterone concentration in male individuals. Let's look at other face details like the eyebrows, for example. The loss of the outer third of the eyebrow actually is typical for a more than 4-year-old thyroid deficiency, hypothyroidism. Thin eyebrows in the middle is very typical for a 4 to more year old of growth hormone and IGF-1 deficiencies. And if you have a loss of the inner third of the eyebrow, that's typical for low testosterone levels since very long, since generally 4 or more years of low testosterone. So just looking at the face gives you already clues, because the patient who actually has those signs actually has also the fatigue that accompanies it, the fatigue of a person with the lower third of the eyebrow missing is a fatigue of thyroid deficiency. That's mainly in the morning, and then slowly when the person moves gets better and better. While the fatigue of a person who has very thin eyebrows in the middle is exhaustion. That person cannot recover. Even if that person stays 12 hours in bed, the recovery is not total, because that is what happens when you have a growth hormone deficiency. Well, the loss of the inner third of the eyebrow is a person who has a sort of moderate background fatigue all the time that aggravates when they do physical exercise. So eyelid signs, the dark circles under the eyes, that's typical for Addison's disease with low cortisol levels and compensated by an increased stimulation of the pituitary gland by ACTH levels. And the ACTH gives pigmentation. So you get pigmentation, you get pigment spots, but you get dark circles around the eyes. Ear signs, the ears can be firm, that of a young adult, or of a person who's growth hormone deficient like this, droopy, older adult ear. Can even enlarge because it's actually getting more droopy. Heart signs, let's look at arrhythmia, for example. Arrhythmia, when it's slow and you don't hear the sound so well, is typical for hypothyroidism. Irregular heartbeats, when it's quick in stressful conditions, so it doesn't happen all the time, like in hypothyroidism. Well, when it's quick, that's typical for cortisol deficiency or magnesium deficiency. And when the arrhythmia is very quick and constant, like an atrial fibrillation, if there's a hormone problem, it probably will be hypothyroidism. So just by listening to the heart, you can get already close to diagnosis. And let me remember you that what happens in the cells will express themselves in the heart cells by rhythm changes. So here we arrive then in physical exam part 2, where we'll see the trunk and the lower part and the limbs of the body. And there's in this first consultation for diagnosis, and we will look at the fingernails, we'll look at the fingers, we'll look at the palms, we'll look at the back of the hand, and also of the palm of the hand. We'll see that a little later, the wrist, the forearms, the shoulders, the upper arms, and the elbows. So we'll start here, and I'll show what I'll be showing on the video, what I do actually. And we'll see a lot of insights that will fascinate you. You'll think that just by looking at the hands, you already got everything from the patient. Of course, you still need to control the rest, but you can get already a lot just looking at the hands, examine the hands. So that science will be taught. Also, the abdomen, when you palpate it, what to mark the body here, the back, the legs, also the thighs, the knees, the lower legs, the heels, the feet, the toenails, the weight, the body composition, and also the Achilles reflexes and the knee reflexes. They give you information, hormone information. And we'll see also here breast examination, what it may give as a clue for hormone dysfunction, and also genital areas, vulvar and vaginal. And then we'll see also for men, the penis, the testicles, and the prostate. So really interesting, where you think that's maybe something not good, but you have never made the relationship with a hormone deficiency. After this session, you will know it. So let's look at some of the pictures. If you have hypothyroidism, you have cold hands, and they are also swollen in the morning, not in the evening. Generally, they deflate during the day. And then you have extremities are bluish or reddish because of poor blood circulation. There's not enough oxygen in actually the red blood cells. So they lose their red color. Also, for example, for the nails, what we can see, you see all these lines, that's typical for growth hormone deficiency. And that improves within 6 to 12 months of adequate treatment. Longitudinal lines on fingernails. Also, insulin deficiency has typically a sort of a triceps, a droopy triceps. And you find that also in protein deficient diet, because when there's insulin deficient, you have low normal insulin, for example, you're not able to absorb amino acids from the food easily. So you get droopy triceps, you get the result of a protein deficiency, even though you're eating enough proteins. And then when we look at the abdomen, for example, the abdomen can be bloated above the navel. That's typical when the stomach bloats. In the middle, they can be bloating abdomen. That's typical when the small intestinal bloats. Or the lower belly can be bloating. That's typical when their colon is bloating. It's a little, now, nutritional wise, a bloated upper belly, when the stomach is having problems and is accumulating the food, it can be due by a lack of hydrochloric acid. And hydrochloric acid, this stomach acidity is necessary to absorb amino acids, to digest proteins, and then we have amino acids that can be absorbed. So that doesn't happen well if you're lacking hydrochloric acid. The bloated middle belly actually is generally due to a lack of pancreatic enzymes. The pancreas that makes insulin makes also digestive enzymes. Those are lacking when the middle belly is bloating and your small intestine is getting over full with food that it cannot digest well. And the bloated lower belly is typical when you have low probiotics or excessive bad bacteria there. So there's dysbiosis in that case. So if ever your belly is not flat at the end of the day, you should not eat large meals in the evening or you have problems. Well, if you have that, then think about that, because if it's bloating, you're having a problem and you can correct it. Now, also we'll look at the feet, for example. Aldosterone excess is swollen feet at the end of the day with pitting edema. And hypothyroidism is swollen feet at the beginning of the day. So swollen feet, upon awakening, when you get out of your bed, that's low thyroid. And it's non-pitting edema. It's really hard feet, but they do lose some of this mixed edema, so they lose the swelling during the day. Well, with aldosterone, it's the opposite. You get more swollen. Well, aldosterone is a water-retaining hormone, so if you stand up a lot during the day, you will accumulate fluid because aldosterone gets up and it will withhold water, and the first part of the body that accumulates the water is the feet, and it's a pitting edema. You can push and you have a pit that stays a certain time. Hypothyroid toenails are generally white toenails. You see they're more whitish because there's not enough blood circulation going there. I'm having a little interference here, but I cannot take it away. Okay. So the laboratory hormone test here that you see here will be looked over in session 4 for about 18 hormone deficiency and 18 excesses. And that will really have some fascinating results that really will be helpful for your practice. So let me show you some of the slides. So the first consultation has laboratory requests with interpretation. And then we go to blood hormone test. We'll give you the panel that I proposed and also the instructions to give for the patient. In the 24-hour urine hormone test that I will abundantly explain, you'll also have specific instructions for the patient to do the test well. The 24-hour urine is put in a vial like this. The blood is here, test tube. We also have saliva tests we'll talk about. In some circumstances, they have value, and laboratories and addresses to give to the patient-specific test. Then we'll look at the specific thyroid test, and then the adrenals, the insulin, the sex hormones in men and women, the growth hormone, IGF-1, melatonin, calcitonin, parrot hormone, oxytocin, and vasopressin, how to interpret tests, and an example of a lab test interpretation, a patient case that we'll have, where you see the lab results and how the analysis is made. So the advice is to do a large panel of tests at the first initial examination, if it's possible, financially for the patient, or for it's possible in your country for the insurance, or because you have a good lab. Because it will help to screen all the important hormone deficiencies, because if you just correct part of those, you often have an imbalance that doesn't work so well. So what to check? Baseline biology or hormone assessment, very important, nutritional assessment, and also the pollution and now all the other ones that we ask are necessary because they contain parameters that are influenced by hormones. Cholesterol can be changed by hormones, so it's important. On the other hand, if there's not enough cholesterol, maybe the patient cannot make hormone based on cholesterol like cortisol and testosterone. So you really need to have a large view, certainly at the first initial examination. And then the lab tests are blood, saliva, and 24-hour urine. That's the basic testing. And these are the tests I asked. There's a little X here in the places that I asked. So if you want to overview, you have that, but you get more details about that easier. You'll have a copy of that if you go in this model. And there's different for men and for women. There's not much difference, but there are some differences, especially in the sex hormones and the cancer screening. Now, an important instruction for the patient is to drink 2 or 3 glasses of water 1 or 2 hours before blood withdrawal for hormones. Otherwise, you have blood concentration. You should avoid that. So you make them drink water before the blood test. And you see what happens with the blood concentration. You see, this is all the big molecules and all the red blood cells are compressed. There's more in a small volume. And so all the levels of larger molecules increase because they cannot diffuse to the pores of the blood vessels. And you have high levels typically of high hematocrit, high hemoglobin, high urea, high creatine. So it's good to ask these tests so you know if there's hemoconcentration. But you also have another idea of hemoconcentration, but you check the hormone plasma binding protein, the proteins that transport in blood the hormones to the target organs. And they are also all high. TBG, that's for thyroid, cortisol, sex hormones, growth hormone, etc., IGF, by binding PP3, they all increase when the blood is concentrated because they cannot leave the blood. And they have hormones attached to them, and those hormone levels are then artificially increased. And this can give misleading information because you would say, oh, the levels of the hormones are high. No, because they're inactivated because they remain in blood. They don't go in the target cells. So it's a false picture. So that's why patients should drink a lot of water, enough water at least, before the blood test in the morning. They should not be dehydrated. You should have an empty stomach, but please, they should not be dehydrated, not lacking water. So the most important test for each hormone are seen. Let's look for growth hormone IGF-1, for example. We'll see that the growth hormone in blood is not valuable because it's very little secretion, if ever, and there are some peaks, but you'll probably not be a peak. It's not reliable. The hormone, growth hormone, is mainly secreted the first 2-3 hours of the sleep. And that's not the good timing to do a blood test because the patient is asleep. IGF-1. IGF-1 is a hormone that is produced mostly due to the presence of growth hormone. So growth hormone stimulates in the liver the making of IGF-1. And that's quite stable value. So you have an idea of growth hormone's metabolic activity and the IGF-1 production on itself. And IGF-BP3 is important to ask because it's IGF binding globulin 3. It gives the information on how much of IGF-1 remains in blood. If there's high levels of IGF-BP3, there's a lot of IGF-1 that remains in the blood and will not go in the target cells. It may not be too high, IGF-BP3. So that gives an idea of the bioavailability, the ratio between IGF-1 and IGF-BP3 gives information on bioavailability for the target cells. And when we look at the deficiency and you look at it, you see that there are certain levels actually at which below in most men and women, there are deficiencies. But here's the clue. We'll talk this in more details in the session, is it depends on the height and the muscle mass of the patient. A patient with a lot of muscles and who's big and tall needs more high levels of IGF-1 than a person who's thin and small. So we'll talk about how to discriminate the difference. But below certain levels, you already can think that the average person at least will be deficient. And so we'll talk about these levels more abundantly. So the ratio is again important here. And you can even do a 24-hour urine for growth hormone. And also some levels are also inadequate in that. So we'll also give an example of a patient. For example, this patient that we'll examine in more details will show that his low testosterone levels is actually 308. Is comparable with values here at 308. There's an increased risk of erectile dysfunction, of depression, of coronary heart disease. There may be a possibility of type 2 diabetes, fatigue loss, or higher mortality, but not as sure as for the other disease. It means that a patient who's low normal actually can have a lot of disease. You see all these levels actually are also, the lower the level is, the more you have abdominal obesity, you have type 2 diabetes, you have arteriosclerosis, etc., sarcopenia, Alzheimer's disease. So it's good to have optimal values. And actually for testosterone, for a person of average size, he's actually, bizarre enough, he must be in the upper range to be 100%. And that's not really what you should aim. You should aim the average or a high normal value. But it just showed that at least for these studies here, you better be higher if you want to be healthy than at the lower level. It justifies also treatment to treat a person who's still within the reference range, but low normal. Hormone therapies, we'll talk about how to treat with growth hormone, melatonin, thyroid, etc. It's second consultation. When the patient comes back, the lab test results have come in. And we'll give some basic tips again, and always little pearls that help you to do better the hormone treatments. And for example, using bioidentical hormone in most cases, especially if there are psychological complaints that are predominant. And then we'll talk about melatonin, growth hormone, thyroid, all different glucocorticoids. We'll have a good overview, but an overview that really permits you to treat with doses, know how to do it. The DHEA, aldosterone, pregnenolone, insulin in this first session of hormone treatment. What we need to know is that what happens in medicine, in let's say conventional medicine is generally not a medicine where you treat the causes of problems. You treat the consequences. For example, if a person has hypothyroidism, that person will have unexplained weight gain. There might be pharmaceutical drugs given for that, or a weight loss program to the patient. If the patient that is hypothyroid has constant fatigue and tiredness, patient will take coffee, for example. That's a drug. Antidepressants, if for the depression of hypothyroidism, muscle soreness, there will be anti-inflammatory and anti-pain drugs given. And synthetic progestrogens for in vitro fertilization when there are menstrual and fertility problems that actually at its origin is hypothyroidism. If they have a dry skin, there will be skin creams given. And for high cholesterol, there will be statins given and arterial hypertension, antihypertensive. Poor concentration, there will be cholinergic drugs or ginkgo. That's conventional medicine, efficient to treat symptoms, but by treating only the consequences, it also gives side effects that are not desirable. And you know what? One treatment could treat all of these things. It's not a bulletproof option, but there is really a way to relieve the patient from taking all these other things just by giving thyroid treatment. And generally, they even feel better than with the collection of medications and drugs that they may take. So tips to implement is that, and that's really very valuable, is that hormone treatments work better if your food is good. And the food that seems to be the best, at least for adrenal hormones, for sex hormones, for growth hormone, is the paleo diet, the diet of our ancestors, where they were vegetables, there were fruits, and there were protein-rich foods like meat, fish, and there were also nuts, etc. They didn't have bread. They didn't have milk products. Didn't have sweets. Didn't have Coca-Cola. They didn't have alcohol. And that really improves the efficacy of the treatment. So here's, for example, information that we give for cortisol, hydrocortisone. These are the doses to give if you use the bioidentical one. Hydrocortisone is cortisol, it's a synonym, it's the pharmaceutical name used in pharmacy for cortisol. And that gives energies, a good stress resistance, and low blood pressure. Prednisolone is a synthetic derivative, and you give smaller doses because it's more active, and you only have to give it once a day because it's long acting. But it's better used for inflammatory diseases like allergies, rheumatoid arthritis, or eczema. And it has a 24-hour action, which is a good thing compared to hydrocortisone, which doesn't stay in the body long because it's quickly metabolized. And then you have methylprednisolone, quite similar to prednisolone, so slightly lower doses are given. And you give it's for people with high blood pressure or overweight or fluid retention, or you need to give very high doses. Better to give this one because it doesn't retain fluid or not much, so that it helps better. But otherwise, if it's really just a real deficiency and there's no inflammatory disease, no high blood pressure, and no overweight, it's the hydrocortisone to give. Also, we'll talk about certain treatments like melatonin, how to adjust them to jet lag, for example. When you know that jet lag syndrome really makes people crazy. Now, there's been a COVID crisis and there's less people traveling, but when they travel over long distances, you get the jet lag. And that actually jet lag creates melatonin deficiency that gives you difficulties to fall asleep on time and difficulties to remain asleep. When you get up, when you wake up in the night, you cannot fall back asleep. That's typical for melatonin deficiency. So when you take melatonin when you are going to have a jet lag, well, if you go, for example, from Europe to the United States, go westwards, night comes later, so you have longer days. You should take melatonin once you arrive at destination at bedtime. And actually, you should always take melatonin when you go at bedtime. And we'll talk about how much doses you have to increase following the number of hours of jet lag. So you do have an insight. But the basics is you need to not take it 3 hours before you go to bed, but at bedtime, and you take a higher dose with some other nutrients like 5-HTP or GABA that may help further to treat jet lag. Then we'll talk about hormone therapies, and that will be on estrogens, progesterone, testosterone, and even thymosin alpha-1, MSH, IGF-1, even erythropoietin. And basically, at this consultation, we'll talk about some of the lab test interpretation to adjust well the treatment, but we'll mostly talk about for each hormone therapy about the routes of administration, what is the best route, the safest, most efficient doses to give. Progesterone and dydrogesterone synthetic derivative that is very safe compared to other synthetic derivatives. Testosterone woman, testosterone men, MSH like melatonin 1 and 2, PT141, etc. ACTH, parrot hormone and calcitonin, IGF-1, androstenedione, and so on, EPO. So basically, you'll have a lot of information. And now let's look a bit on oxytocin treatment and routes of administration. For oxytocin, there is a sublingual form that is, if it's well made, often the best. What patients prefer best, and I personally take, in general, sublingual oxytocin. But you shouldn't take more than 5 to 10 units, except if there's a severe autism in your patient. Intranasal, often more than you take higher amounts, like 2 times 8 to 16 international units per day, because it seems not to work as well. And then intravenous, subcutaneous, you can take up to 2 times 10 international units per day. When it's intravenous, it's basically for delivery that is used. So that's not for the current doctor in general, more for the gynecologist. We'll also talk about the explanations to give for the patient. We give written informations. You can give a copy of those written informations. Like this one, for example, you see that sort of information is given so that the patient knows when it's too low the dose or too high, and can also participate in finding the right dose. And then we'll have a follow-up consultation where we'll look at complaints and a lot on physical science, because the science of physical examination seems to be lost in many doctors. There's not enough information on university, and they don't have time to learn that somewhere. So here you with pictures you have, and all these pictures are before and after pictures. And then we'll also have a good information on how to interpret lab tests, how to really know if the result is low. So when you look here at the face of a person here, we'll look at how the scalp hair can change from one consultation to the other. Even male pattern baldness can be reversed, and we'll show pictures of that. Face, eyes, nose, lips, tongue, cheeks. We'll see all pictures before and after. The chin even, the body, the chest, the blood pressure, the abdomen, the genitals, the shoulders, the upper arms, the elbows, forearms, hands, thighs, knees, feet. Prepare you, if you follow this session, to get a lot of really fascinating information, like you're in the consultation and you see 2 consultations together. The first initial consultation and then the third when they come back in treatment, and you see the change. So that sort of change will be shown in pictures. Now, you also have some tips on how to improve the efficacy of hormone treatments if they're not efficient enough, how to decrease factors that adversely affect the hormone treatments, how to increase the safety, and to follow up the lab test. So which lab test to do, and we'll have example of a lab test follow-up. So to know is that the aim of the treatments, you are healers. You're driven by spirit to help people, not as a savior, but as a person who just responds to what the other patients wants to have as information, and is ready to take. And that goes in the direction of optimal health and appearance. So that's your job. Make them optimally healthy and looking good. So in the follow-up, we'll check symptoms for improvement. And again, a follow-up question is necessary. So there will be a PDF with a follow-up question you can use. And you also ask additional questions at that moment. There's maybe some questions that needs to be answered. That's the time you do it in the follow-up. So you check the body for improvement. And here, for example, the hair. How do we reverse with testosterone and a 5-alpha reductase blocker? You see what the results. This is what you can see after 5 to 10 months of treatment. It starts very shyly after 4 months. And so this is sort of improvement you can have. So the key is not only give finasteride, but also give transdermal testosterone at the same time. So we have here sagging cheeks with nasolabial folds, and they get firmer cheeks without nasal labial folds. Now you see this sort of improvement. The body transformation before and after. Look at the change in body just with thyroid therapy. Here is thyroid treatment with heel fissures and these yellowish foot soles, and with treatment you give vitamin A and thyroid, you see a change, less carotene colored, and the fissures are disappeared. Also, we should check the lab test for improvement, and we'll give some ideas of what is an optimal testosterone to reach in the follow-up in a woman, for example, here. Should be average to high normal. We'll explain why and how you can do it safely without getting masculinization. The free testosterone, depending on which type of lab you have, is 5, but in other labs it can be 8 picograms per ml would be a good average. You have to be average. And then understand diol gluconide, a little error here, should be 2-3 nanograms per milliliter. Otherwise, this is a metabolite of dihydrotestosterone, the hormone that can give masculinization. So it may not be high, but it may not be low also. Otherwise, there's regression of genital error. So we'll give you the figures that you need to strive. And then the transporter, the protein that transports testosterone in blood, sex hormone binding globulin, should be high normal in a woman. In a man, should be low normal. Then we'll have patient cases. And we'll have then patient case that actually I'm not going to talk about that here. I want to leave time for the questions. And there will be a session on frequent questions from patient cases, but that won't be videotaped. It will just be a PDF, how to answer the questions with data, information, and basically what are the questions we'll see. And maybe those questions can all be served can be partially answered in the question and answer session we're going to have now. So how quick come improvements with each hormone treatments? Do hormone treatments suppress the activity of the endocrine gland? Patients are really afraid that if they take the treatment, it doesn't, it damages their gland. I can tell you, if you do physiological dose, it's okay. And do hormone therapies cause cancer? So will be extensive information on that. Why do they have to take so many hormone nutritional supplements? Why is the treatment so expensive if it is? Why do other doctors say that disced thyroid is an old-fashioned product? What is the scientific evidence to support hormone treatments? Why do many physicians disagree with hormone treatments? We'll have good answers to all these questions, how to avoid, etc., how to motivate patients, and legally how to secure yourself as a health professional, as a physician doing so. So here I'm at the end of my lecture. We'll have now the possibility of getting Dr. Jacob Teitelbaum just show you some information about to join the evidence-based hormone therapy postgraduate program cycle 1. And well, in this cycle 1 that has been is totally prepared, there is an extensive, very interesting model on how to treat infections, whatever the infection is, but also the COVID-19 infection, the immunity, the inflammation, and inflammatory disorders, 3 sessions in it. Really interesting how all the hormones, but also nutrients can help. Reversing physical aging, that's the most successful of all these models. You can just register for one model of the whole cycle. It's cheaper when you go in the whole cycle. But this is 8 sessions actually. Female hormone supplementation, chronic fatigue and burnout, with a lot of fantastic information. Not only hormones, but also nutritional therapies, thyroid diagnosis and treatment, melatonin, testosterone in men, and testosterone in women. I have more information, but I'll show that later about cycle 2 that I'm starting now. And I'll invite Jacob to Teitelbaum to start his video and put his audio on. Good. And I'll stop sharing here my screen. And I think when we click on you, okay, good. There you are, Jacob. Jacob, I think you are you're having also a good experience in hormone therapy, and we'll focus a little bit more on that. When did you start your first hormone therapy in a patient for chronic fatigue syndrome?
Soon after I came down with chronic fatigue syndrome. Those of you who know my story, I had post-viral chronic fatigue syndrome in medical school, knocked me out of medical school and left me homeless in 1975. Part of my recovery was learning about the need to treat hormonal deficiencies, in my case, especially low adrenal. So my first hormonal treatment began in 1976, treating myself.
Wow. And so basically, when you have a patient with chronic fatigue syndrome, are you doing a hormone investigation in them in the first hand, or are you doing it then in a second step?
I do it before I ever see the person. It is so important, so critical, so routine that hormonal issues are present when you see people with chronic fatigue syndrome, fibromyalgia, ME, and post-COVID issues. That, again, this is part of the initial blood test before I ever see the person. And it's fairly extensive, looking at a detailed thyroid, adrenal, and reproductive hormone levels.
Okay, so you mostly work with thyroid and adrenal hormones and testosterone and estrogen and progesterone. And do you do also multiple hormone replacement therapy? Or are you just focused first on one and then maybe on the second if it doesn't work enough?
These things all work in concert, so they often need to be given together. I will start one new hormone every week or so, because if you're going to get side effects with people, you'll usually know in the first 3-4 days of starting something, even though it may take 6 to 8 weeks to see the full effect. And there's so many things that need to be done. If you wait 6 to 8 weeks between, they're going to be 100 years old by the time they get through everything. So start a new treatment, give it 3 days, then you can be adjusting that, adding in the next one. Some people need to go slower, but that's the general model that I use.
And how frequent do you see your patient the first year, for example, and then the second year?
Usually every 3 months, and until they're feeling well for 9 months, or pretty close to that. Then it'll stretch to every 4 to 6 months. When they're feeling well, it's once a year.
It's once a year. Okay. Do they come to your office, or you do through telemedicine, through internet?
Mostly telemedicine. It's a mix of both, but I treat people from all over the world.
Yeah, and then with telemedicine, you can easily treat everybody. They don't have to come to your place. Now, when a patient comes out of your office, how many supplements do they have? Nutritional and hormone, is it 10 or is it 5 or is it 20? Do you have an idea?
In the beginning,
the average?
It's probably closer to about 10 to 15. And then we'll add things in. I try to remember when they come back for follow-ups to check what things are helping, what things are not. And it's very good because the tendency is just add more and more stuff. And then the person just can't do it anymore and they leave. So it's a good idea to have them note what things they're taking that help, which things that don't help, which they're not sure. And go down the things that don't help. Consider getting rid of those if you can, before adding in the new things at each visit.
And so you do a lot of explanations that you explain to people why they take it, or do you give them papers so they have the explanation, they need to read it at home? How do you do it exactly? Are you a teacher, or are you
I'm a teacher and a healer?
I'm sure of that.
And I'm not the boss of the person I'm treating. I'm their guide. And if I don't give them enough information, I'm useless to them, because they need to know what's going on so they can make informed decisions. To make this easier, I have tools, both questionnaires and treatment checklists that go through all the details. Here's what it is. Here's your range of dosing. Here are side effects to look for. So these are make it very easy. And in fact, I'm happy to share those. If anybody wants to email me, my email address is fatigue, Fatigue, doc, like doctor@gmail.com. Just let me know you're a practitioner, ask for the treatment tools, and I'll send you several of those and some recent studies we completed. But definitely, I explain things more so they understand, and I'll do it in English since I'm in the United States, but using analogies. I'm not going to do it in technical medicine thing because they're not going to get that. So I talk about, for example, the hypothalamus. I talk about it being like tripping a circuit breaker in your brain because there's not enough energy, you trip the circuit breaker. I'm not going to talk about CRH, TRH, and I'm going to say that circuit breaker controls sleep, so you can't sleep, hormones, so your entire hormone system goes offline, autonomic function, so you stand up, blood rushes to your legs and stay there. So I'm going to use simple things, but I'm going to have them a good understanding. And I also advise people at the beginning of treatment to never do anything that feels uncomfortable to them. If they're not comfortable with the treatment, they need to let me know so I can give them more information. And if they're still uncomfortable, I honor that as their psyche saying, that's not for me, and I will go on to other alternatives.
So you have actually a very great respect for the patient, and you're really trying to see what is the personal treatment for that patient. You're not going to do a sort of standard treatment to everybody. You're really going to adapt it. And you're also probably listening a lot to your patient and questioning. So now you have you're treating now people with COVID. I mean post-COVID syndrome, because that's also post-viral syndrome. What are the abnormalities you find in their blood test that you check? Do you check some, like, I know there's more coagulation after the COVID, or you don't check those parameters? You mainly check the hormones that have been, for example, the adrenals that have been damaged by the COVID infection?
So here's the thing to understand post-COVID. Any of a number of viral infections, and there are over a dozen, and COVID is just one more of them, can trip the hypothalamic circuit breaker, make it non-functional. And that causes a lot of downstream problems. As we mentioned, the hypothalamus controls sleep, so they can't sleep. That needs not testing, but to be addressed. But for the hormones, you're going to see a different pattern on the hormone tests. Remember, we're taught to treat, oh, well, TSH, if it's low, they're hyperthyroid. No, because the hypothalamic pituitary axis is not working. It was funny, when I was lecturing at the World Conference in Italy, Professor Gunther Nieck was there, and I asked, in post-viral chronic fatigue syndrome fibromyalgia, is TSH useful test? And he is the main TSH researcher in post-viral chronic fatigue syndrome. He said, absolutely not, it's useless. So it's normal to have to drive the TSH very low to get optimal treatment because of the hypothalamic dysfunction. So we're going to do thyroid, adrenal, mostly just ACTH and cortisol levels will be the main things that I look at. And you know, and then I'll do the testosterone, the female hormones, and things like that. I don't do as much as I should with the growth hormone. And in fact, I think I'm going to stay and listen to more of the rest of your conference to learn more about the growth hormone and the oxytocin treatments. We do find oxytocin can be helpful, but I don't do any testing for oxytocin.
There's not so much testing possible for oxytocin. It's more in research labs. But you can just try it, and it usually works then. Now for growth hormone, it takes the exhaustion away. Actually, the most severe type of fatigue, in my experience, and also IGF-1 gives us. It's really worth, I think, to learn that, because many people get definitely tired the whole life. They think it's aging, that's just an adaptation, but it's just growth hormone deficiency. Then when you correct it, it's like a miracle. I myself had a sort of exhaustion that went away with growth hormone, and so that makes my motivation very high. If I don't take it 2 days, I have to sleep 2 hours more, and I'm tired all the time and anxious.
How long did it take you to see the benefits when you first started the growth hormone?
Well, it does take a certain time. So, but in some patients, it may be quick. Let's say you need to say it's mostly the second month that you need to, you get improvement. But I had a patient who said to me, was severely chronic fatigue, 3 years. I gave all the treatments, was 30% improved, but was so severe, said to me, look, if you don't improve me, I will suicide myself. It has happened to me several times, but please, patients, don't give that information. But then I had an insight. I said, look, there's growth hormone. Maybe that helps. And actually, I didn't know it, but I felt that it's going to help. And that patient in 5 days was dramatically improved, then stopped the treatment because of a scare of growth hormone, and fell back into the exhaustion very quickly, and then took it again, and then was better for 2 weeks, and then stopped again exhaustion, and then took it again, definitely, and terrible things have happened to that woman later, but she went over, was like a spiritual leader, I would say. Unbelievable how this changed. It's also a spiritual hormone, I find, because it calms your body and it gives you're not handicapped by tenseness in your body, and so you can feel the world much better with it. I got to be more spiritual with it. Well,
good.
That's that.
Yep. So there's a lot. I will note, for those of you who have patients who say that they're thinking of killing themselves, although legally you need to do what you need to do, I simply ask them, I tell them, I cannot treat you if you're going to hurt yourself. I need you to promise me that while under my care, you will do nothing to harm yourself. And the promise may be given grudgingly, but if they give the promise, I've never seen one in over 3,000 people who have gone on to hurt themselves. People will honor that promise, and it's enough when they're on the edge of not being able to stand it anymore. That promise may be enough to keep them from going over the edge. Yes,
you're probably even a better psychologist than I am, so that's good. But it's true that I think one of the best motives for people to improve is actually that they have the choice to improve. That if you inform them, they can choose. You're not just giving a treatment, you're proposing them a treatment, and they make the choice. And they make the choice to live better thanks to the treatment or not. And it's true that I respect patients, and then I do, when a patient doesn't want to take a treatment and absolutely needs it, then I explain, and I will say, look, I'll give you 2 choices. I'll give you the choice I think is ideal for you, and the choice that is adapted to your desire, and that will be more or less efficient, but probably not the same efficacy as the other, but at least you have the choice to make the treatment you're okay with. And generally, almost always it happens, they take the bigger treatment because finally they thought it over and they had the choice. And so I think that's respectful, but you have only the choice if you have the information. And I think you and I know well that it's so efficient when you're really informed. Now, I did see, and that's for the physicians that are listening, something very important, that if I testify that I'm taking the treatment too, and you give me that and that improvement, that motivates them terrible. And actually, I learned this from an American physician that you probably knew, Broda Barnes, for the thyroid. So my father always said to us as a physician, don't tell other people that you're taking thyroid treatment. So I thought this was the standard. But Broda Barnes in his conference said, I'm taking the thyroid hormones. And actually, he had a great success because he gave confidence in people. So I think it's very important for a physician helper to testify about the treatments. You testify, for example, Jacob, that you had post-viral fatigue syndrome. Then you're one of them, of your patients. You're part of the club. So I think that's great. And we don't have to, I think, and I'm sure you agree, is that we don't have to hide what we're doing. I think it's our greatest force is to say, look, I have this problem. What do you think about that?
We're taught that we're not allowed to be human. We're supposed to be God, and we're supposed to ignore the patient and disrespect them and tell them what to do. And I can't imagine a worse recipe for healing. So the important thing is for people to know, they understand. If you can say, well, I've been there too, I've had these symptoms. How do you think I can explain them to you so well? Because when I do that, how did you know that? I said, because I had it. I know what it's like to be there. And I've done these treatments. I know what it's like. And I'm generally going to try most treatments before I offer it to other people because I need to know what it's going to do. So these things of honoring and working with a person, we are not the boss of them. We are their guide. And to the degree we empower them, then we're doing healing. Otherwise, we're wasting their time and ours.
Yeah, I'm saying something else. I'm saying I'm your consultant, and but you're the boss, and you're your health manager, and I need your help because then it's a teamwork, and they accept that. And as you, actually, I've never started in a patient a treatment without trying myself. I even acknowledged that I tried female hormones on me. Only 3 days, because it was at that time I tried it, was not in fashion to change your gender and things like that. But I felt so well with it, with the estrogen and the progesterone. I was really, I would say, really well. And then I stopped after 3 days and I went into depression for 1 day, terrible depression. At that moment, I made a vow, I will never, never leave female hormone deficiency untreated, because I know what difference it makes. It was so pleasant to benefit from it. Now, actually, later on, I learned that by taking testosterone for men, I make then more female hormones in the right balance, that this is the better way for men. But basically, it did help me a lot to do this by myself. So you really know how important it is. If I didn't try growth hormone myself, I wouldn't think of giving it to patients. I know what difference it is. Now, there is, of course, always this condition that is, if a person drinks alcohol every day, the growth hormone won't work. And so we need, I need also to repeat that sort of information. Now, let me see with the time. Yes, we still have time for questions. So what would be your protocol for, let's say, a typical case of fatigue syndrome, and then a typical post-viral COVID syndrome?
So what our research showed, and this was a randomized, double-blind, placebo-controlled study, intent to treat analysis, good solid study, showed that giving what we call the SHINE protocol, optimizing sleep, hormones, and hypotension, that means orthostatic intolerance, infections, nutrition, and then exercise as able, not too much exercise where they crash and burn, they get post-exertional malaise. Doing that resulted in 91% of people improving with an average 90% increased quality of life, P less than 0.0001 versus placebo for all the outcome measures. So this is the core program. Sleep, again, there are many natural things for sleep. I'll use a sustained and immediate release mix of melatonin. I will use the medications, low-dose trazodone, gabapentin, Flexeril, or cyclobenzaprine. I will use what's needed, but a very, very low dose of several things instead of a high dose of one works best, where people are hungover and they don't tolerate it. For the hormones, everything we're talking about here. For the Cortef, I do try to limit the hydrocortisone to 20 milligrams a day. As you noted in your talk earlier, and by the way, I thought your presentation was one of the best things on physical examination I've ever seen in my 45 years of medicine. It was awesome. That's one of the things that left me saying, I want to stay and watch the rest of this, come on each week with you and watch the courses in the audience. But in our research, we did not see any adrenal suppression up to 20 milligrams of hydrocortisone a day. But going to 25 milligrams a day, you will begin to see adrenal suppression. That's sometimes necessary, but you will see it, and you need to be aware of that when it comes time to wean. Up to 30 milligrams a day, very rarely you'll see the side effects of Cushing or anything like that. Over 37.5 milligrams a day, you're going to start to see the effects of excess. But so just to be aware of those things. But the Cortef hydrocortisone, I use that very frequently in my practice, and it's very, very safe as long as you're keeping it under 20 milligrams a day.
Yeah.
Do
you use also fluorocortisone, aldosterone, the synthetic aldosterone?
Mostly what I'm going to do, when you talk about the hormones, we also mentioned hypotension, which is a lot of people have low blood pressure, one, because of the low adrenal, but the hypothalamus controls autonomic function. We're a big bag of water, we stand up, gravity sends all the blood down to our legs. Think about it. We had to evolve a system where our body and the legs send the blood back up to the brain and muscles and heart. It's called the autonomic nervous system. And again, hypothalamus controls sleep, hormones, autonomic function, and temperature regulation. So that system is going to be off. When you see people who can't sleep even though they're exhausted, You know that beyond normal thyroid, adrenal, testosterone, growth hormone issues, they trip the hypothalamic circuit breaker. It's not working. So again, people come in, they say, I'm exhausted. I hurt all over. You ask one question, can you get a good night's sleep? They say no. You know their hypothalamic function is off. And that needs to be addressed in a comprehensive thing, that a single hormone thing is not going to take care of it. So how do you treat? We talked about the free tools I can send you. Happy to send you an orthostatic intolerance information sheet that will have 2 tests. One, just a questionnaire from the Mayo Clinic Journal, and another one, it's a pulse test where they lie down and stand up and tell how to do it and how to interpret it. And that's all of this is free, all the stuff I'm talking about. And we'll send that to you if you want. Just email me. Sure. And it will give the detail of going with the Florinef, DDAVP, as well as Midodrine, increasing salt, water, compression stockings, and the whole list of how to address orthostatic intolerance. So I saved the fludrocortisone for cases when I have a sense that orthostatic intolerance is present.
Okay, I do see that a lot of patients who receive hydrocortisone actually do worse with it. And the reason is generally then they are low in aldosterone and that I have to give fludrocortisone. So I give easier fludrocortisone. I'm taking myself fludrocortisone and hydrocortisone and DHA. Unfortunately, had a problem with the vaccine. So basically I aggravated my adrenal deficiency and I'm on higher amounts of hydrocortisone now. Otherwise I cannot function. So, but the fludrocortisone is also something unmissable because otherwise I get very low blood pressure. Okay, now I have seen one thing that is very important in your program. You had exercise. And exercise has another thing is that most of the exercise you do outdoors. And light increases hormone levels. For example, if you go from a dark room into a lightened room, within minutes you have more than 50% increase in cortisol. And you have more receptors for cortisol and less receptors for melatonin, so that actually you wake up better. So I think your exercise also works because of increasing the light, and you improve the hormones of the light. Like there's 20% or 30% more thyroid hormones, I think, in the morning. And testosterone is also higher in young men, and thanks probably to the light.
Yep, exactly. Going for a walk outside in the sunshine as able, but don't push beyond, don't encourage people to push beyond what's comfortable, or they will be bedridden for 2-3 days after. They need to listen to their body, and because there's only so much they can do. But after 10 weeks on the SHINE protocol, their energy production will skyrocket, and they will be able to start increasing their exercise. Terry, can I mention 3 recent studies who did on some nutrients that are very helpful here? Part of what we'll see also is immune deficiency. We did a study looking at people with CFS who had low total IgG or IgG subsets, in addition to having CFS or fibromyalgia. And then a second study looking at people with CFS and fibromyalgia who had either any cause or post-viral CFS, ME, fibromyalgia. And there's a bipeptide amino acid. It's fairly remarkable. It's called recovery factors. It's made out of in Europe, out of the Netherlands and Germany, and that it's a serum bipeptide product. And a colleague of mine had mentioned it to me, and we were seeing dramatic results. We got a couple bottles, so he and I did the study. 60% of people improved, an average about 70% increase in energy. Productive antibodies went up 14%. Sleep improved, cognition improved, anxiety went down, bowel function improved, all of these dramatically. So we have a new tool, and this worked equally well in post-viral CFS. So you can find it online in Europe. It's www.recoveryfactors.com. We did another study we recently finished with red ginseng, HRG80 red ginseng. Similar responses. I use recovery factors more as intensive care. The red ginseng, I just take that myself if I have a busy day. It's a chewable red ginseng, and it's very good. That's a Euromedica product. And then for adrenal fatigue and stamina, there's another study that's currently underway using ribose, ashwagandha, rhodiola, schizandra, green tea extract, and licorice. I'll have results on that in 3 weeks.
Wow, that's good. And the recovery factor, that is a sort of amino acid, or what is it? Or is it also plant extract?
It goes way beyond, it's a serum based, so it's not plant, it's animal based. It goes way beyond. To say that amino acids, that just like amino acids is like saying that any letters are like Shakespeare. It's just, they're very, how they're put together, the way they're absorbed, the effect is way beyond anything I would expect from normal amino acids.
Wow, and it stays on. It's not just a short-lived effect. It stays on as long as you take it.
Yes.
Okay.
Yeah, we have seen dramatic results for people with it.
Wow. Oh, that's good.
For those who email me, I can send you the two studies. One has been published and the other has been submitted for publication.
Okay, it's always the same email, huh?
Yes, fatiguedoc@gmail.com.
Okay. Also good. Now for fibromyalgia, for example, is there something different for the patient with fibromyalgia in the treatment than for a person with chronic fatigue syndrome?
No, same disease in most people.
It's the same disease. Okay.
You'll have a small percent of people who have no pain with it, but it's still the same underlying process. Same with ME. Yep. And again, these three, if I take 100 people with any of these diagnoses, they're going to have 100 different situations.
Yeah, so it's always another hormone balance, non-nutritional balance, but basically we'll probably provide the most important hormones.
The hormones, I'm going to address it, candida in some, and some they were raped as a child. I need to address that. Which of those three labels you use really is meaningless. It's just, they tripped the hypothalamic circuit breaker.
And the key is personalized treatment. So that's really good. Now, you did have a different protocol, I thought, for the post-COVID syndrome, the people who stay sick after having the COVID with other problems than just the infection.
Absolutely. So here's the thing. Post-COVID is post-viral chronic fatigue syndrome and fibromyalgia. So what we talked about for that still applies, but you also have other issues. You're going to see a large percent of people will have microglial activation of the brain with brain fog. You need to use low dose naltrexone, 3 to 4.5 milligrams at bedtime. Start slow, work your way up. That really helps microglial activation considerably. You're going to see continuing widespread infection. You had the clotting issues that were going on. You had the clots and bleeding both, and you have basically anytime little bits of blood get into tissues, those are free radical triggers, one of the most powerful that there is. So you need to turn off the oxidative stress in the brain, in the heart, in the lungs. And for that, I'm going to use a form of curcumin, but I'm very picky because it needs to be a highly absorbed one. And I'm going to use either Curafen or Curapro because these one pill replaces 7 regular pills. And I don't use turmeric because it would take 350 turmeric pills to get one. So I'm going to shut it down with that. I'm going to use glutathione as well. So I'm going to shut down the inflammation. When there are heart issues, I advise people to get a pulse oximeter. A lot of these folks have shortness of breath, but it's not coming from heart or lung problems. I am get a pulse oximeter, $20 on Amazon. Zach V-Rate makes a good one, but really any good pulse oximeter. And if the pulse oximeter is, oxygen is 96 or more and they're short of breath, it's not from lung problems or heart problems, especially, and I'll tell them, walk up a flight of steps. And if the oxygen level is going up, not down, it is not a lung or heart problem, and that gives them the peace of mind. If they have heart issues, anybody with heart issues, I don't care if it's from heart attack or congestive heart failure or arrhythmia, there's a free phone app called Cures, C-U-R-E-S, capital A-Z. It has everything from acne to zoster. There's a $2 upgrade. It's optional for heart. The heart stuff's all on the free one. Look up heart disease, and it'll give you a recipe. Ribose, coenzyme Q10, magnesium, B2, hawthorn even, and it'll go through a list of things that dramatically increase cardiac function. So I live in Hawaii, and there was this older man there, and I bumped into him, and he and his wife were talking with me, and they said, oh, they came here to Hawaii because he was going to die. The doctor said he had 2 weeks to live. and he wasn't going to freeze in Alaska. He figured he'd die in Hawaii. And the doctor said, there's nothing I can do for them. And I said, the doctor was right. There's nothing they can do for you. And I gave him this recipe of their ribose and all these things. And 2 years later, I got an email from this guy, subject heading, "You saved my life." There is so much you can do naturally that is research proven, incredibly effective. And the doctors know nothing about it because it's cheap. So when you're treating the post-COVID, you address these things, the lung problems, these will be helped by what I said, and the lung generally with shock lung, over 2 years that resolves and heals itself. Reassure them.
Okay, good. Wow, perfect. I did just had a patient who had had the COVID and was doing fine actually, but I'm knowing now the problems. I'm checking some lab tests, and there's a lab test called D-dimers, which are coagulates of fibrinogen. And the patient, they should be around 200, and they were 3,700. That means that she immediately has to go to hospital because of a high risk of thrombosis and a blood clot. And actually, then I put a protocol on of the hormones that prevent fibrinogen, the protein for coagulation, to come together. And the protocol includes high doses of testosterone in a woman and DHA. I also give coenzyme Q10 and very high doses of melatonin, like 40 milligrams. And in 24 hours, her 2,700 value fell down to 900. And I hope it's still going down because there was a more a profound treatment. I also propose to take more growth hormone IGF-1 because it's also fibrinolytic. That means that it prevents fibrinogen to coagulate together. And so I think the results will be good. It did decrease my D-dimers very much, also in a week time, here in 24 hours. So there are treatments with at least hormones that can improve very much. So there's hope to treat the post-COVID syndrome, post-vaccine syndrome, and all these. But you said yourself, I think, in another interview I had with you, that following you, it's the same problem. The post-vaccine syndromes, people are not doing well with the COVID vaccine and the COVID. Huh? Can you elaborate more on that?
Yes, we're seeing that a smaller group of people, it's about 10% who get COVID, symptomatic COVID, will have post-viral chronic fatigue syndrome. So that's the one group we were talking about. And again, the vast majority of those can improve the treatment dramatically. We even see people who post-vaccine are getting post-vaccine chronic fatigue syndrome. Now, you can't talk about that. That's not, no, you're an anti-vaxxer if you talk about it. That's crazy. You know, this whole thing, it's become so politicized. There's a researcher who's an immunologist, just a very, middle of the road, staid researcher. And he's an immunologist. And he found, we're seeing these shifts in people post-vaccine who get fibromyalgia and chronic fatigue syndrome. And I think we can reverse those. And he said, let's use Miraviroc, which is an AIDS drug, and ivermectin and a statin should reverse these immune things. So he gave those to the people and they got better. And I gave it to one of my people with severe disabled post-vaccine. And within 3 days, she was feeling much better and able to go back to work. But then suddenly he said, oh, no, not the ivermectin. That'd be, in the United States, it becomes so politicized. You give ivermectin, they think you're a quack and they want to kill you. So he saw the politics. He said, well, not the ivermectin, we'll put something else in. But yeah, so even for the post-vaccine, that protocol has been shown to work. But I would suspect that the rest of the protocol also will be enough in most people, the rest of the SHINE protocol, to help them recover. Even just addressing the adrenal issues would be such a key thing there.
And I think those who have a post-COVID syndrome have a worse adrenal working, and also with the vaccine, I think it's the hormone deficiency that is the most frequent behind causing. But I do think that the COVID or the vaccine of the COVID can cause actually a lot of different problems following the predisposition of people. That's why it's so difficult to be sure it's from the vaccine or it's from the COVID. So it's very, very difficult. Okay, we have questions. So I propose that we're going through the questions, and Here's a question. Does oxytocin supplement impact FSH and LH at men? What form of oxytocin supplement you recommend? I don't know if the oxytocin has an impact of FSH and LH. I don't know if you know, but the supplements is best to have sublingual ones, but they can only be purchased, I think, in the United States. Or there's a firm on internet, I may not name the firm, but that sends it from Asia, I think from Hong Kong or Singapore, that can have a very good quality supplement oxytocin. Otherwise, you take the intranasal. Officially in Europe, for example, intranasal oxytocin is made by a pharmaceutical firm and is available in the Netherlands and in Switzerland, but can be sent to the other countries from there.
And in the United States, it's available from Anazao Compounding Pharmacy and the sublingual oxytocin. Last I checked.
Okay, good. There's also, I think, a pharmacy in San Diego, UCP, that has very good quality. Okay, I see some Spanish. There's a lot of breakup in connection, so that's I left with cognitive issues. Well, no. What do you think about ashwagandha to treat low cortisol? I think you can answer better.
I think it's critical. The smart energy system that we've put together, which is research that's ongoing now, I use only the KSM 66 form of ashwagandha because the brand matters a lot. So any of them that have that 300 milligrams twice a day, it's very good. But I'm going to add rhodiola, schizandra, green tea extract, licorice, and ribose. That combination altogether, which is what the smart energy system is, that can see dramatic benefits. But yes, ashwagandha good, dose 300 BID, use KSM 66. I have, by the way, I have no connection with KSM 66 or any of these things. I have a small connection with recovery factors because I've done all the research and the rest for them. And I sell the smart energy system, but anything else I'm talking about, I have no financial tie whatever with them. So,
okay.
You know.
Okay, but so you would use anyway a combination of ashwagandha, rhodiola, and some other nutrient.
Rhodiola, yep, and green tea
But
extract.
you can find them in your books now or not? These
Yes, and my newest edition of my book, From Fatigue, fantastic. This is a shameless plug. Everything you need to know, including the hormones to get these people well, you're going to find pretty much in the From Fatigue to Fantastic, the blue cover new edition. It's as health practitioners or even for the public, it will walk you through step by step and make you an expert. Okay, that's my shameless plug for the day. So,
no, but it's good because I think everybody should read your book. So
well, thank you.
I think so. Here's maybe a more specialized question. What treatment would you suggest for exhaustion combined with adrenogenital syndrome? The problem with adrenogenital syndrome is that there's people with cortisol deficiency, and because they have cortisol deficiency, the adrenals make other hormones like androgens, male hormones, more, and they can add more. Women can get more body hair growth with that, and the treatment is normally to give cortisol. Now, if there's exhaustion, really exhaustion means, in my instance, means that you cannot recover anymore. You stay tired all the time, even if you sleep a long time. Then you need to add growth hormone, but the problem is that when you're cortisol deficient, the growth hormone decreases the cortisol. So fortunately, we have here, we can get IGF-1 in our country. IGF-1 has almost the same effects as growth hormone, but it regenerates the adrenal glands. So you make more cortisol with it. Well, with growth hormone, you make less. So basically, either you give low dose growth hormone with hydrocortisone and DHA always in combination, but little DHA with people with adrenogenital syndrome. And or you give IGF-1, which is much safer. So when we have people with cortisol deficiency, we propose IGF-1. The problem is it's very expensive. There's a synthetic derivative that you can purchase on internet, one acting IGF-1, but you don't have the guarantee of quality you have with the real IGF-1, but usually they do work and they are 5 times cheaper. So what is your experience with hormones in vitiligo? Maybe I can answer that. Well, hormone, we don't have so much good effects on vitiligo. Vitiligo, in my experience, is due to yeast infection. And so we've always put yeast creams, and then we get a sort of repigmentation just by putting anti-yeast creams on the skin. And usually these people have low cortisol, so they have more autoimmune disease. And by giving the cortisol, you don't aggravate the vitiligo anymore. So there's sort of anti-yeast treatment, also better food that you have to take, no milk products, no sweets and sugars. And then cortisol treatment, but cortisol is always with a little DHA and other hormones. Do you have any experience in vitiligo?
Well, the main thing that I'm going to be going with in vitiligo is there are creams that help to repigment. And the best, instead of going through all the details, the best thing to do is to call your compounding pharmacy, because the pharmacist there will often be familiar, asking for the repigmentation creams for vitiligo. And that helps in 1% of cases.
Okay, and you don't know what is it?
I would have to look up each time to see what the components are.
I'm interested.
That's what I was actually doing while you were talking. I was saying I could hunt it down quickly, but I didn't have it.
Okay. What is the amino acid complex from recovery factors you're referring to? Apparently, I think we've answered that. What are the doctor's name, please? I don't know which doctors we're talking about. Did you give any other doctors? Your name is Jacob Teitelbaum. My name is Thierry Hertoghe, so I don't know if there's any other name to give. Thanks. Talking about high prolactin.
Well, let me note in the Netherlands, Dr. Paul van, if you're looking for somebody to refer to because you're new in what you're doing, Dr. Paul van Mierendonk in the Netherlands is superb at treating CFS and fibromyalgia. For those of you in Europe, I treat people worldwide, but being right there, it's so much easier logistically for him.
Yeah, I know him. Yeah, he's a good guy.
Yes, indeed.
I had to help him at a certain moment. What are thanks? So high prolactin in young non-pregnant ladies. What can you suggest? Thanks for your wonderful info. Okay.
So the thing is that prolactin is not just a thing about are you making milk. Prolactin, one is a reflection of hypothalamic dysfunction. So when you have hypothalamic pituitary dysfunction, you're going to see elevated prolactin. But the other thing is that prolactin is a very rough indicator of the dopamine function. So high prolactin to me suggests low dopamine, and I'm more likely to give agents that will increase dopamine. Conversely, a high prolactin, which again, but the low prolactin suggests high dopamine. And I may give even things like Zyprexa or Abilify and tiny dosing Abilify, not the 15 to 30 milligrams for schizophrenia, but 1/30th of a milligram, one drop. Research out of Stanford is showing dramatic benefits with that.
So repeat the name maybe that you're giving of the product you're giving for low prolactin, if I understand, no?
So for those that are interested, when you email me, ask for the Abilify, ABILIFY information sheet. This is probably some of the newest research out there, and we're seeing very good responses to it. It's a medication, but you're just going with a liquid, and it's literally 1/30th or less the normal dose. Other things that raise the dopamine, you're looking at basically the amphetamine class of medications, phentermine, things along those lines. And in a group of people, they can be very helpful. You are not kicking a dead horse with it. You're restoring dopamine balance with it.
Now, one of the good ways to decrease prolactin is to treat the hypothyroidism. So TRH, hormone of hypothalamus, is more secreted when there's hypothyroidism, but TRH also stimulates prolactin. So, by providing thyroid hormones, it decreases TRH and prolactin decreases. So that's one of the ways. Of course, it's also a sign there's a lot of stress. So maybe a person just needs to relax more, but they should check their thyroid when the prolactin is high.
What about, other thing, let me note one quick thing. What most doctors, they see a high prolactin and somebody who's not lactating, they think, oh my God, pituitary adenoma, cyst in the pituitary. What we have found, we often see high prolactin. Usually I will wait 3 to 6 months because with the SHINE protocol, it almost always comes back to normal. If it does not, then I will check an MR scan of the head to look for pituitary adenoma. Okay.
Anyway, it also depends. If the level is very high, you need to check the scan because it's probably a tumor. Okay. Here, what about DHEA? Well, DHEA is a hormone that is secreted in the same quantity when at young age as cortisol. It's only that it slows down with age much quicker than the cortisol. So there's an imbalance that will favor aging. But if you correct the balance, it's okay. So I almost never give cortisol or whatever without DHEA. Because otherwise there's an imbalance that will break down tissues more, and DHA is the safeguard when you give cortisone. I don't know if you have the same experience.
Well, basically, my impression is that giving the DHEA decreases the risks of toxicity by giving cortisone by itself. So combining the two,
yeah.
And especially if I have somebody with autoimmune disease, 200 milligrams a day of DHEA, even in women, has been shown to help lupus. These are double-blind studies. So if I'm going to check the level, I want to keep the level about 80 in women and about 250 in men. I usually give about 5 to 10 in women and 25 to 50 of DHEA in men if the levels are on the low end. But if I'm giving high dose cortisol, you've got to give the DHEA because otherwise you run the risk of more side effects from the cortisol.
I usually say that if you give 20 milligrams hydrocortisone, you need to give 20 milligrams of DHEA. And because it's actually, they are produced really at a young age, like 25 years, in the same quantity per day. So I suppose that might be a good strategy. But I hear then Dr. Teitelbaum and Dr. Hertoghe, I understand that glutathione should not be used in patients with mercury amalgams as it will leach out. Can you please comment what you would recommend?
Okay.
On that.
so look, glutathione, a key function is detoxing people. So if anybody has any toxins, when you first take it, you may pull those toxins out of their resting places, the fat, the teeth, even for the mercury. So it may pull it out a bit. And then you're going to know if the person wants it, because if they're feeling worse, then you're detoxing them too quickly. If they feel okay, the body is saying no problem. So again, that glutathione, it has to be reduced. To give oxidized glutathione, it's useless, and most of them are. Has to be absorbed. Most are not. They get digested into the system. So I will use a form called clinical glutathione, which works well. But I use it mostly if I have somebody that I'm detoxing on purpose. For the mercury, again, it's a whole big area of heavy metals that is very vaguer than we'd like to make believe. The test for heavy metals, look at the bottom of the sheet where it says in bold typing that this result was not meant to be used for people with challenged levels. We gave them the DMPS or another chelating agent. And you say, well, it's high. And the test in the bottom says, these normal ranges don't apply if you gave that. So we don't know. Now, that doesn't mean heavy metals are not critical things to do, but my feeling is I will give the glutathione when I feel it's needed, like especially post-COVID. If the person feels much worse with it, I will stop it and then go more slowly and consider other forms of far infrared and other detoxification.
Are you giving oral glutathione, and what dose if you give it?
I just use the clinical glutathione form because that is reduced and that doesn't get broken down. Most people I'm going to give is N-acetylcysteine, 1 gram BID, 1,000 milligrams twice a day, if I'm really needing that. Otherwise, I'm giving 500 to 650 milligrams a day. The vitamin powder I use called the Energy Revitalization System, that has glutamine, glycine, and cysteine, which if you have those three together, your body will turn it into glutathione at whatever speed it wants to. So I prefer to give it in that way, glutamine, glycine, cysteine, let the body turn it into glutathione, unless there's something specific like Parkinson's or post-COVID or things like that, where I will use a clinical glutathione.
And the name is Energy
Revitalization System.
Revitalization System.
It's a vitamin powder that replaces 50 tablets a day of vitamins and minerals and amino acids.
That probably, yeah.
It's yeah, we have it in the US, but it's excellent.
Okay. What do you suggest for a woman with sagging face and lips and nasolabial wrinkles? That person needs growth hormone, and also improve the digestive tract, because people who have sagging face and those folds usually have a bloating upper belly. So they have to stop eating proteins in the evening. That's too heavy for the stomach. My SHH is high and my magnesium level is high as well. What hormone could I take? Well, probably if SHH is high, that person has a lot of pigmentation and is low in cortisol. So probably that person needs to have cortisol or hydrocortisone. And for tone loose in the body skin, it's mostly growth hormone that improves the tone of loose skin. But you also need to have a good food. If you eat a lot of sweet sugars, it may not work well. So you need to stop. You need to go to the paleo diet. What do you think about the combination protocolo, niacin plus melatonin, niacin for post-COVID, post-vax? Thanks in advance. What are you?
I'm not a big fan of high-dose niacin. I think everybody needs some niacin, preferably is niacinamide. But overall, the research using the niacin initially being used for high cholesterol was this main thing, has shown that the risk of it triggering diabetes is just higher than the benefit. I don't use the niacin.
Okay, so
except in like 50
triggering
milligrams.
diabetes was niacin. If you go higher than 500 milligrams, or what would the dose?
If you go over 1,000 milligrams of niacin a day, you run the risk of increasing diabetes.
Okay.
And not just that, the flush is very uncomfortable for people. So I personally abandoned that protocol 30 years ago.
Okay, but the niacin that gives a flush is a dose that is more than 500 milligrams, or you can already have flush it, something like
usually if you're under 1,000 milligrams, you're fine. You may get the flush even with 30 milligrams, but you're not going to get to diabetes.
Okay. I did take niacin in a congress at I think 500 milligrams. I got a fantastic flush 10 minutes before going to speak. It was
this may look like a Christmas tree up there.
Well, at least I never forget it. Just use symptoms to use oxytocin rather than basing it. Yes, I think for the moment it's mostly using symptoms of low sociability, no orgasm or low orgasmic intensity, social anxiety, being afraid of meeting people. Then oxytocin works well. Now there is, I think, a lab in the United States in Seattle, Meridian Valley lab that checks oxytocin in the urines 24 hours, I think. And even in dry urine. What is the cost of a complete treatment for an 80-year-old who is in good health? Well, the cost of a treatment at our place is, for example, at the pharmacy. It's mostly the pharmacy that you need to pay. That is, I think a treatment is easy from, let's say, $3,000 if we use dollars to $5,000, $6,000. There are always less expensive treatments that can be made, but then you don't get all the hormone treatments and all the nutritional therapies. How much does the treatment cost with you? I mean, if they buy medications and they pay the consultation, you have an idea?
Well, for me, my new patient visits are 3 hours of my one-on-one time, and for that, it's $2,950. In terms of the supplements, usually about $300 a month for the first year or so. In terms of prescriptions, most people have insurance coverage for those. If not, in the United States, the pharmaceutical charging system is utterly insane. They just make up numbers and charge that. So you'll see for the same medication in one pharmacy might be $10, it can be $300 in the other pharmacy, $1,000 at the third. So there's a phone app for those of you in the US. Have the people you treat use the Good, G-O-O-D, RX phone app. It's a free phone app, and if they're paying out of pocket, it will keep them from being raped at the pharmacy. It usually brings the pharmacy prices down about 95%.
Wow, that's a lot. So you're giving a lot of different addresses, and I'm getting questions. What is the exact address? Because they don't have the time to write it down. They don't understand
the main. My email address is fatigue.
And there they get it off.
CUEDOC@gmail.com. From there, you can email me and ask, what was the pharmacy that had this, or what was the phone app? Yeah.
Okay, great. That's great. Do you know how we can find the products and hormones in Italy? Well, many of them can be found at the pharmacy. Now, in Belgium, for example, when we work, we have a pharmacy somewhere in Germany that sends what we cannot have in Belgium. There's a pharmacy in Italy that sends what we cannot have in Belgium. So basically, it's in European country, it's very difficult to have everything in the same country. But we have the European Union, and so there's other countries with other legislations where the products are available in most of the time. What did you say that we can find at Amazon? I don't know. It's probably almost of all those recipes. Here's a longer text, but I don't think we'll have time to go over that. That's the person who takes pregnenolone, melatonin, T3, DHEA, lab test, etc., etc. The lab test shows still a low DHEA, so DHEA is not now for DHEA. When you check DHEA in blood, and you're taking a treatment, you should 3 days before the blood test take the DHEA in the evening and not anymore in the morning. So when you take it the third night, the DHEA, the next morning you do a blood test, it's about 8 to 10 hours after you get the average blood level in DHEA you have with the treatment. So I think this person may have a low DHEA while this person is taking twice a day, 50 milligrams, which is normally a huge overdose. I don't think the DHEA is good, or the patient stopped the treatment before the lab test. But normally, if they take it in the evening, they get an adequate blood test if the level is good. Testosterone is very high here in this person, but the free testosterone is low because this person has a high SHBG. Now, hormones are transported in blood by most of the hormones by a plasma binding protein. If the plasma binding protein is very high, it keeps the hormone in blood, and the hormone does not go in target cells. So this person, has a high testosterone, but SHBG is very high. It's enormous. It should be 30 and it's 110. And so the free testosterone index, the amount of testosterone that goes in the cells, is very low, 40, and it should normally be 80. And a lot of female hormones, I think it's in a man. And so what I can say in this person is this person makes too much female hormones that will block the male hormone, that will also give to a man prostate hypertrophy and breast formation. And so this treatment is not well balanced. That's all I can say. And probably the hormones have not been taken at the right time to do a good evaluation. Can you use the growth hormone and growth hormone releasing peptides, hormone peptides instead of growth hormone? It is after age 30 or 35, using an amino acid or peptide that stimulates the secretion of growth hormone doesn't work well because there's not enough cells left to make growth hormone. So you cannot stimulate enough. And if you do, it's okay for 6 weeks, but then after the effects die off. So the best is to take growth hormone when you need it. And you can additionally take growth hormone releasing hormone. 5 minutes more. Okay. Where we can find the list of supplements that are good for the heart, please. But I think they can email you and they get the information.
Dr. Cures A to C phone app.
Okay, good. Doctor, I'm from Indonesia. I had palpitations and tachycardia after injecting Pfizer for the first time for 20 hours intermittently. After that, it went away. What hormones affect this? Look, I have a friend who has heart decompensation, got two times the injection and had COVID also before. So I think his heart decompensation comes from that. Each time he puts testosterone and he has tachycardia, and it's very, very dangerous tachycardia, ventricular tachycardia. That means that he may go, his heart may stop working from one moment to the other. Well, he just puts testosterone here and it goes away. He did, because he likes to do double-blind placebo-controlled trials. He's a physician, a famous professor. And so he puts the skin creams on for cosmetic, and that doesn't work. But when he puts testosterone, it decreases. And testosterone is known in several studies to decrease heart arrhythmia, especially auricular fibrillation. So that may be a way. And also, yes?
So if I can add one thing to that, the godmother of pain management, Janet Travell, who wrote the Trigger Point Manual, she had a cardiologist friend who found that atrial fibrillation all the time, and she just injected the muscle trigger point where there's a reflex arc between the superficial muscle of the heart, and the atrial fibrillation would go away. And you'll see with a lot of things like that there's arcs between the muscles, the skin, and the organ. And what I find is if I have an injury, I'm going to put my testosterone cream over the area of the injury to speed healing. If you have the muscle issues, like what they're saying here, where the muscles may be tight, triggering the reflex arc, the magnesium and the testosterone both release those muscles and can help. So that's just a little add-on to what you're talking about with that.
Interesting. So you said that physician or I don't know, therapist injects on places of trigger points to decrease auricular fibrillation.
Yes, there's a specific trigger
So
point that's
which
associated
trigger
with it.
point? Which
I'd
trigger?
have to look that back up in the book again. If you you can look up atrial fibrillation and trigger point on Travell, it'll probably come up online.
Oh, that's it. But I suppose it's a zone that is contracted, and when you touch it, it hurts, and that
Yes.
zone is injected. Now, okay.
Yes.
So now also to know is that because I had this bad reaction with the vaccine, I have also ventricular tachycardia and things. I paid very high amounts of melatonin. I usually always propose very small amounts because not more is necessary to sleep, but I take very as protection 40 milligrams in the evening of melatonin. I'll take it probably for 6 months and maybe longer. I don't know. But I think that's a fantastic antiarrhythmic substance. In studies on animals, it can decrease by 90% the number of irregular heartbeats when it's in animals provoked. What about androstenediol gluconide? Androstenediol gluconide is here is the metabolite, the main metabolite of dihydrotestosterone. Dihydrotestosterone is the main hormone that gives masculinization in men and even in women, the body hair growth. And that converts in the cells to androstenediol gluconide. Now, what is the major androgen in blood? Not testosterone. Androstenediol gluconide in men is in very high amounts, and even in women also. And so basically, if that marker is high, men will have too much dihydrotestosterone and will lose their scalp hair. And women will also can lose hair and get facial hair. So it may not be too high, but when it's too low, you get regression of genital areas. You get penis atrophy, you get lichen sclerosis in women, vulva, and clitoris that shrinks. So it may not be too high, not too low. If a patient with terrible insomnia doesn't recover with melatonin nor ashwagandha, etc., and has high ketosis in his body, what hormone could we recommend? Growth hormone is, there are two hormones of the sleep. Melatonin makes you fall asleep and fall back asleep. And then there's growth hormone that gives you the deep sleep. So the hormone that person needs growth hormone, or if that person has adrenal deficiency, should start with IGF-1 if that is available.
And I would add progesterone and
progesterone. Oh yeah, that also makes it. You can also give it to men, progesterone.
How do you dose it to men?
Well, you cannot really dose the oral progesterone very easily because it doesn't have a plasma binding protein that is very strong attached to. The plasma binding protein of progesterone is transcortin, cortisol binding globin, the one that transfers cortisol, but the attachment of progesterone is very weak, so it goes quickly in the cell. So you have to judge on symptoms, the evolution. And the doses that can be given is 50 to 100 milligrams of progesterone. And that makes you also sleep better and things. Alopecia universalis, help please. That's alopecia universalis. You need to provide thyroid hormones, which helps to get the hair back, but you need also to give injections of ACTH. Injections of ACTH give all the hair that comes back actually, except the hair on the sides. The hair on the sides needs sex hormones to get back. So I treated several cases of total hair loss, and you need then those hormones. You start with thyroid and some ACTH injections.
Does that include alopecia areata from autoimmune causes?
Areata is mere cortisol deficiency or yeast infection. So you treat with locally anti-yeast products, you give them an anti-yeast diet, and you give them cortisol, and that goes very well away. Of course, in balance with DHA to cortisol. Use peptides, IGF-1, probably that person is talking about long-acting IGF-1. I have used the long-acting IGF-1 during 8 months. It gave me the same efficacy as the regular IGF-1, but I have to give it a good example. So I'm taking the bioidentical IGF-1, which is more expensive. And they both help in fatigue. You take the exhaustion away. Hello, what is Dr. Teitelbaum approach to multiple sclerosis and Hashimoto? Well, I think you need more time for that, but maybe very shortly, because we
Yes,
have
it's the same. Secondary chronic fatigue syndrome from many autoimmune diseases is common, so I will treat that. I will also, of course, use the low-dose naltrexone with the MS. Beyond that, I'm going to use many of the normal MS treatments. I will consider heavy metals and other things in that line, but predominantly I'm going to be treating the secondary fibromyalgia.
Okay, and you're probably also giving high dose of vitamin D or not?
Of course, high dose vitamin D for pretty much every autoimmune disease, and many people with fibromyalgia also need that as part of the N in Shine.
So what dose would you recommend?
Even depending on the blood level. And again, I don't chase blood levels because you're going to find a lot of vitamin D blood levels are low in people with fibro because they're converting to the calcitriol 125D, which then suppresses immunity. So again, if it's low, I may give 50,000 units a day, a week for 12 weeks. But then if it's still not coming up, I'm going to check the calcitriol level. If that's high, I'm going to keep the vitamin D to 1,000 units a day because then it becomes a double-edged sword.
Okay, do you check parathormone? Because it seems that parathormone is high, you need more vitamin D. It's a sort of...
It depends on the calcium levels to whether I check PTH.
Okay. Okay, then there are some cases, a person with Addison's disease with anti-adrenal antibodies. No, they were negative here. It's in Spanish, so I must translate. Okay, CTH is normal. Okay. What are the diagnosis for Addison's disease? Se puede ver este caso. You can have Addison's disease normally is just high ACTH and low cortisol. If you don't find high ACTH, it's maybe because, and that's the most frequent cause, the lab test is not a good test kit. That's just that. And so you cannot test in that lab the ACTH. You can know if the person makes too much ACTH by looking at the physical signs. If the person has dark circles on the eyes, spots, Addison spots on the face, here all the folds are more brownish. The armpit here, the folds of the fingers, the three creases are brownish, more brownish. That's Addison's disease for sure. And you just need to treat the low cortisol and often the low aldosterone, and the low DHA that they have. Buenas tardes, and what is here a person, can you start a treatment, hormone treatment, when you're, as a woman, still lactating a baby? Yes, you can, no problem. You just need to give bioidentical hormones.
I would note that in my practice, thyroid and cortisol, I will continue through pregnancy because they support a healthy pregnancy.
Yes, very good. The cortisol takes out the nausea and the vomiting. Here they say we have to stop. So sorry for the little questions that are still there. I thank everybody of attending, and I thank you, Jacob, for doing a really fine job. And if you want to get access to the presentations, there's no problem. I think there are a lot of really interesting, even although you know maybe much more than I do about chronic fatigue. I think the one on chronic fatigue will interest you particularly because there's a lot about hormone treatments also. And so you can have access to what you want.
Yeah, it's an awesome lecture. It's not that often that I have that much to learn in anyone, but you're a fount of information, Terry, and you're amazing. Thank you.
Well, I take the information from everywhere, and so here it is. And I have the chance of meeting a lot of people and getting very curious. And you know, I really think, and I've talked to you separately with this, that we're being inspired by higher force. And I'm just the transmitter of the information. So I'm thanking also the ones who send it to me, even if I don't know anything. Okay, well, thank you. And I thank everybody. We'll end it here. Let's stay in contact, Jacob. It was really a pleasure for me to interview you. You've been really great, and I see the reaction of people are very, very interested of what happened. Bye-bye, everybody. See you next time.
Hi, everyone.
Oh yeah, wait a minute. There's a little information I need still to share you, and is I have to go back to give you information. I was forgetting that. I have a little job to make. is we talked about cycle 1, and there's also cycle 2, which is starting now, the hormone therapy consultation, which I just presented. There's 8 courses, one PDF lecture. Adrenal hormone therapies, we're having 6 courses there. Growth hormone, IGF-1 therapy, 6 courses and 1 PDF. Really fascinating. These adrenal hormones and growth hormone, are those also used for the post-COVID syndrome that might be very necessary, and for all chronic fatigue syndrome, psychological disorders, even schizophrenia, autism, anxiety, stress, depression, a lot of what hormone care therapies can do. Then there's another one here on extending longevity, really interesting. But actually in this extending longevity, we have in all these courses, nutritional courses that have been taken separately. So there's 3 nutritional courses additionally to it. There's only 3, but it's 6 in total. But cardiovascular, cardio and cerebrovascular, 8 courses with everything you dreamed of: stroke, hormone therapies, and coronary heart disease, high cholesterol, and so on. Sexuality, hormone therapies, and oxytocin treatment, 5 courses, and obesity, hormone therapies, 4 courses in PF. So that's cycle 2. I think really interesting, and I hope many health professionals will subscribe. And we have done this nutritional therapies that is also the first year. It's a nutritional program. There will be cycle 2 will be also come later. And everything's well structured. It's very interesting. So for people who are not physicians, who are nutritionists, you have this also. And next events will be, save the dates, October 27th. There's a online question and answer session for those who register in the modules. And that's really helpful because you really can ask the question. October 21st, there's each management conference, but I wonder if it's not changed in the meanwhile, because everything changes with the COVID. There's also November 6th, an online Congress Health Masters Forum. I think it's in Portugal, and which I'm participating. And there's one in Saudi Arabia. I'm participating in International Genetic Disorders on November 26th. And on December 7th, we'll have a new free exclusive webinar on the adrenal hormone therapies, cortisol and so on, DHEA. So that will be the presentation with also a speaker. And so don't forget this date. You can scan here if you want to already register your QR code. And for books, if you want to order books, you have here the Hormone Handbook, which is really the bestseller, I think, in how to do hormone therapy. I don't know if you have read it. You have that book.
It's the Bible of understanding hormones. It's just the best book ever written by anybody. Get that book. You know.
And additionally, you have the Atlas. Do you have the Atlas?
I don't have the Atlas.
Okay, I will send you the Atlas free. But it's really helpful. It has a lot of pictures, more than 650 pictures of 20 hormone deficiencies and 19 hormone excesses. So you really can recognize the signs.
If you can sign one for me.
Yes, I'll sign you one for you. And there's also patient hormone handbook, which is cheaper. You can get them all here. You can also scan the code, hertoghemedicalschool.eu. And then we have partners I really have to thank, because they bring also the people who come here. And there's Hertoghe Diagnostics, Labophore, Access Laboratories, who really are very active. Laboratory in Terosian, Saham in Malaysia. They come from many countries. I think we have more than 25 different countries represented here. Your Health, they're in Ireland. VIP Pharmacy is in Argentina, in Canada. Anti-aging systems. If you want to get oxytocin, they have it in tablets. Then here, Pharmacy and Compounding Lab, Sweet Treat. Yvonne Mercury, who helps us from Portugal. Here from Brazil, the Longevitade Group. Laboratoire COPMED from France, ERFA Canada, that's for the best thyroid preparation, I think. They have Laboratoire LIMS, this is the lab that I work with personally, is excellent. Jakarta Anti-Aging Center, GAC. NP Compounding Pharmacy, I think they are in Greece. Isonut Nutrition Santé, Energetica Natura, one of our best partners here in Europe. and University Compounding Pharmacy San Diego also help. Vital Plus, very good. Bionorisso, who are the ones who make the translation. So big thank you for the translation in Spanish. Biosil, Nutri Essentiel, Forsthaus Apotheke in Germany, Qualivita in Barcelona. And special thanks to the Dr. Del Valle, who makes the Spanish translation of Whole Cycle 1. So Dr. Jennifer Del Valle does as a gynecologist, excellent work she does. Everybody's happy about. And here are links if you want to link to the social media here. The Facebook. Actually, I'm not the one who does all that. They do it for me. So YouTube, there's several YouTubes also. And then this is the address if you want to get any information. And if you want to get also the contacts for Dr. Teitelbaum, they can also give you it through here. Okay, well, I think we're finished. Thank you, Jacob. See you later. Bye-bye, everybody.
Well, everyone.
Bye-bye. Voilà.
Gary, thank you. That was excellent.